Hello, everybody. Thank you for joining. Today we're going to cover the Medicare Basics 101 for AP for Part D and C. Definitely thank you so much for joining today. I appreciate it as always. I know everybody's time is very valuable. So kind of just a review. I've went over this before, just kind of showing you the family tree, how we're all set up and how we all relate to each other. We're all under National General Insurance for AHCP, for HST, Health Compare Solutions Team, National General Accident and Health for NHIC, TIC, and then Quote It, the quoting and enrollment platform, and Health Compare, and that's where we get most of our Medicare lines from. So, with bringing them on board and having this acquisition, it's expanded our Medicare lines tremendously and has helped us out. And then we have Agent Cube, the smart CRM, and VeloPoint, our call center for W-2 agents. I've been with the company for just over 3 years. I've worn many hats in several different areas, and I'm sure some of you have either met me in person or have joined on some of the various different webinars, whether it be Motivation Mondays or maybe some of the carrier webinars we've put on. So kind of our agenda is just introduction to the DNC lines, overview, what is Part D, what is Part C, the enrollment periods, comparing the options and reviewing some of the details. And just kind of an overview here of what Medicare is. You have your hospital insurance, your medical insurance, Medicare Advantage plans, and prescription drug plans. Medicare Overview. Medicare is a government health insurance program. It's created for people over 65 or 65, I should say, and older. People under the age of 65 with certain disabilities. So if they've been on Social Security disability income for 25 months or longer, they would qualify. And then people with all ages of end-stage renal disease, ESRD, and then some permanent disabilities as well. CMS is the Center for Medicare and Medicaid Services. It's a government body that regulates the Medicare program, beneficiaries, and health carriers who offer various forms of Medicare health care coverage. The 4 parts of Medicare. You have Part A, hospital insurance, Part B with the medical insurance, it's outpatient services and some supplies. Part C, your Medicare Advantage. It allows people to receive all of their healthcare services through private insurance. It's almost, it's very similar to adding A and B together to make C, but there is some little additional benefits there. And then you have Part D with your prescription drug coverage. So jumping right in, Part D, what is Medicare Part D? Well, Medicare Part D is optional, it's prescription coverage, and it is sold by private companies approved by Medicare. Part D, again, like I said, is optional. It's coverage for those who do have enrollment for Part A and B. Part D is not part of original Medicare. You must live within those service plans in those areas that you're signing up for your plan. Beneficiaries can get Part D one of 2 ways: standalone plans, which we'll kind of discuss in various parts of this presentation, as well, and those are called PDPs, or they can enroll with a Medicare Advantage plan like a HMO or PPO that offers drug coverage. Plans are effective for 1 calendar year. And what parts, of the cost of 2017? Well, you have 4 different stages. You have your deductible, your initial coverage, your coverage gap, your donut hole, your catastrophic coverage. So you have your plan premiums. They vary widely and can change from year to year. Clients can pay their premium penalty if they're late for enrolling in Part D. There's a penalty, yes, if they do enroll late. But some Part C plans also include drug coverage at no additional premium, so we'll kind of discuss that a little bit. There's deductibles included. Some plans have deductibles. The maximum deductible for 2017 is $400, and plans may charge different deductibles for drugs based on the formulary tier. I'll kind of explain what a formulary tier is later. There's co-pays for some of these, and plans may have small copays for prescriptions and refills. The amounts of them can vary depending on the actual tier and depending on the prescription. And then your coinsurance. Some plans may set coinsurance rates for certain drugs or drug tiers in coverage gap. The customer will pay about 51% of the price for generic drugs and 40% of the price for brand name drugs. So an individual is eligible to enroll in that Medicare Advantage plan if the individual is entitled for Medicare benefits under Part A and enrolled in Part B. So if they have A and B, they can get that Part D is essentially what it's saying. They can go ahead, get that set up so that way they have A, B, D, and it has that hospital coverage, it has that doctor outpatient coverage, and then you have your prescription coverage. You put the three of them together. So just kind of looking at your enrollment periods, very similar to if you were looking at plans A and B. For your first eligible, when are you eligible to begin with, or your clients, when are they first eligible? They have that 7-month window. 3 months before their 65th birthday, the month of their 65th birthday, and 3 months after their birthday. And then just kind of looking at the additional enrollment periods, they have an annual election period between October 15th to December 7th that they can drop their plans, they can switch their plans, or they can enroll in a plan. So if they didn't currently have Plan D and they had maybe Plan A, Plan B, and some other equivalent prescription coverage, if they wanted to drop that other equivalent prescription coverage and move on to Plan D, they could. Special enrollment periods include when they move from service areas or lose credible prescription coverage or move into a nursing home. So there are those SEPs available for the Part D as well. And then also, the special enrollment periods where the beneficiary can enroll in a 5-star rated plan. So when it comes to your plans for Medicare D, there are 1 through 5 stars for these plans, and these are definitely rated from when people go in, they get enrolled on them and they make marks on how well they feel that that plan is fitting their needs between their customer service and coverage. So they have a 1 through 5 star rating plan. The plans that are available. They can switch from a lower rated star plan to a higher rated star plan between December 30th and November 8th. They can make that switch 1 time per year if they want to get switched over to a higher rated plan. And here's some just various different options for choosing plans to be able to have Part D. I think there's like a total of 7 different ways that you can set up plans, but this is just kind of giving you an overall look at being able to choose a plan for Part D and how you do it. So, to join an optional Medicare Advantage Plan C, you must first enroll in that Part A and B. So I'm sorry, I just said that reverse. In order to have that original Medicare A and B, you must have that standalone Part D. Or you could do the Medicare Part A and B plus a standalone Part D. So standalone means that it's not tacked on. It will have separate fees and charges to it. And then you can definitely add a Medicare supplement onto that if you wanted to as well, which we'll be covering Medicare supplements next week. But this is definitely an option for them to have A, B, D, and Medicare supplements. Or they can go ahead and do Medicare Advantage Part C with that built-in drug coverage. So that Part D will be built into it. And then you have a choice of doing Medicare C plus the D as a standalone. So instead of doing the built-in, they can do a standalone Part D plan. And just kind of looking, what is a formulary? This popped up before. I didn't cover it a couple days ago, and I wanted to cover it because I had people asking questions about it. A formulary is a list of drugs covered by a plan. Medicare sets standards for types of drugs in Part D, and they get to go through. Each plan chooses specific brand names. They choose generic drug name drugs, and it's all formularies. So plans must have a tiered formulary where the drugs are divided into groups based on their cost. So try to kind of put a little, idea here of what it looks like. So tier 1 is, definitely much cheaper in regards to, the cost, where tier 5 is a much higher, more expensive. So in general, drugs on lower tiers cost the customer less than the higher tiers. Plans charge deductibles for the certain drug tiers and maybe not for others, or the deductible may differ based on the different tier. So I wanted to kind of cover that a little bit because I do talk briefly about the formulary lists. And then what pharmacies can your beneficiaries use? Well, some plans have networks of pharmacies that they have to choose from, while others offer nationwide coverage. So it depends on the plan that they get set up with. And then also they may have that mail-in order offer to, go through, place their order over the phone and have it mailed to them or shipped to them. These types of drugs most commonly prescribed for Medicare beneficiaries is it's determined by federal standards, specific brand names for drugs and generic drugs included in the plan's formulary and list of drugs. Forms of prescription drugs, Medicare Part D plans are freestanding plans that are sold by private insurance companies, so they all are different. Yet they all follow basic Medicare Part D beneficiaries with some incomes above certain levels. I believe that's if it's a single person, $85,000. If it's a joint person, $170,000 income. So it kind of depends on their income, and they have that monthly premium that they have to pay on Medicare Part D prescription plans. So it's based on implementation of Medicare Part D income related, and it's adjusted amount guidelines set for and by Medicare. Medicare is divided into those 4 parts, and it is identified by A through D. So if you don't enroll in Part D when you first become eligible, or your clients first become eligible, you don't have that prescription drug coverage under any other credible plan, like if they're still working and under a group plan. A late enrollment penalty does get assessed, and initial eligibility is 65 or older, or if they have that disability income, they qualify for that for 25 months, then definitely they have that opportunity as well. So they can go ahead, they can check it out. The PDPs, standalone plans, Part D, they'll have a different premium than if it's a built-in plan with the Part C. Your premiums would be built into that. So and again, as I said, the Part D is income related, depending on their gross income. So kind of looking at, their initial deductible, $405 annual deductible. So they do have to pay that deductible off first. And then they have their initial coverage limit. Right now it's $3,750 for this year. It does change each year. So the beneficiary is responsible for paying the co-pays, the co-insurance, as well as their annual deductible. And then they have that coverage gap, that donut hole, which we'll discuss in just a few moments. And then they have their true out-of-pocket costs, and it's called TROOP. Definitely make note of that, because you'll see that acronym pop up a couple different times if you start working with the Part D. And that includes their annual deductible, their co-insurance, their co-payments. It also includes costs of the RX fee. So whatever is in, they pay for that. It's incurred during that coverage gap portion of the standard benefit, including manufacturers' discounts for brand drugs in that gap. And then there's minimum cost sharing for the catastrophic coverage portion of the benefits. So this is if they hit that catastrophic coverage portion, then it's going to help them essentially for their drug coverage costs out of pocket. It's going to their portion will either be 5% or $3.35 for a generic, or a preferred drug that might be a brand name or a higher cost. It would be 5% or $8.35 for the brand names. And then the maximum copayments below the out-of-pocket threshold for certain low-income or full subsidy eligibility enrollees, $3.35 for generic or preferred drugs. It would be $8.35 for all other drugs. So in 2018, there will be a 56% plan benefit. I believe that's 44% retiree paid for co-insurance for the generic drugs, and a 15% plan benefit, which is 35% retiree paid co-insurance, plus the 50% manufacturer discount for brand drugs. So the 44% coinsurance counts against the out-of-pocket threshold, as does the 35% coinsurance for brand name drugs. So, total amount required to reach that out-of-pocket threshold in catastrophic coverage will depend on whether the spending on generic drugs, brand drugs, or the combination. And there continues to be a separately calculated 50% brand drug discount provided by the manufacturer of the brand drugs. So by 2020, the Part D coverage gap will be kind of phased out, worked through, and the combination of additional Part D benefits and brand discounts. So if that beneficiary income is below the poverty line, the premiums are little to no cost. Again, I always remind everybody, please do not tell people free. You can definitely get in trouble for that. So you want to try and say little to no cost. It makes a huge difference compliance-wise, what we can say and what we can't say with Medicare. There is the low income subsidies they can receive if they do have and meet that poverty level. And if the income, again, I pointed out earlier, that income base, if it's over 85,000 or filing jointly, is over 170,000, they will have higher premiums, just like that Part B. And since Part B is also tied to their annual income, it can be a double whammy. So if they're going for Part A, Part B, and then they do Part D, they'll have the premium for Part B as well as Part D both pay. So they'll have additional costs on that. So you need to make sure that it fits within their budget to have that. Then there's the late enrollment penalty for Part D. So if they do not get set up within that, before that 3-month birthday to their month of their birthday to 3 months after their birthday, they can receive a penalty equal to 1% of the national average for Part D premiums for every month he or she is delayed in enrolling. So, their costs can, average and vary anywhere, around $35 a month or something like that. And so it would be 1%. But if they go a couple years on that 1%, then definitely it can be equivalent. It can add up to quite a bit. So it is calculated by multiplying that 1% with the national benchmark premium. There's where it says the average of 2017 was $35.63, which is about 36 cents a month. But then you times that by the number of months they were eligible. So if they were eligible for those 24 months, and they didn't get signed up, or they didn't have, that equivalent prescription plan, then you would do the 24 months times that 0.36, and that's their penalty, and they would have that penalty each year, no matter what. So kind of looking at, some of the biggest downside of Part D is the gap in coverage, commonly called the Medicare donut hole. Most prescription drug plans have a coverage gap called that donut hole. This means that it's a temporary limit on what the drug plan will cover for the drugs. This is a gap between initial payment under Part D when benefits resume. If the customer falls into the gap, then they're responsible for the full cost of the prescription until they reach the other side. So how the donut hole works is each year the coverage threshold for in Part D plans, once they reach that threshold, then their Medicare Part D stops paying for their drugs. In 2016, the coverage threshold was like $3,310. In 2017, the coverage limit is $3,750, I believe. The amount does rise each year. And if they don't spend more than the threshold on the prescriptions for the year, then they won't fall into that gap. The donut hole typically affects people with a lot of medications or pricey ones. The gap between, begins after their drug plans have spent a certain amount for coverage. So in 2017, the coverage gap, once their plan has them and their plan has spent $37.50 on that drug coverage, people with Medicare who get that extra help paying Part D won't enter into that coverage gap. I wanted to make sure to cover that. So if they're receiving that low income assistance for their premiums and assistance, they won't fall into the gap. So if they are on LIS, that isn't something they need to worry about. But, really they have to sit there and they have to get, once, if they are on a lot of pricey ones or on a lot of medications, chances are they'll definitely fall into that gap where they're going to have a lot of out-of-pocket costs that they're going to have to pay until they hit a certain threshold. And then, kind of bringing it down on what the different stages are and how it works out. So you have your stage 1, your deductible or the customer's deductible would be $405. That member will pay 100% of that negotiated rate for their medication of that $405 for that deductible before the plan will start paying on some of that, on the prescriptions. And then there's the stage 2, which is their initial coverage limit. So their deductible is already met. Now we're going to move into their coverage limits. What's their limits? Well, think of this as their shopping credit. What's their credit that they get on being able to spend? So this is the limit, it gets reduced by the plan's negotiated rate of the medication, not by what they pay. So if they pay $20 and the plan pays $100, then subtract $120 from that initial coverage limit. So you're taking what the customer pays and what the plan pays, and that goes towards their initial coverage limit. That's the best way to look at it. And then, they fall into that donut hole once they hit that $3,750 coverage limit. That's kind of their threshold. Anything between that or $3,750 up to that $5,000 is their responsibility to really pay out-of-pocket expense. So that's where they kind of have that gap. They fall in that hole. That's where everything, comes pretty much out of their or to their expense, but they do also get a little bit of a discount on their rates in that regard. So here, they would pay 44% of their plans, negotiated rates for the brand drugs, and 35% for the generics. Their true out-of-pocket costs would have to reach that $5,000 in order to move to the catastrophic stage. As I said, this is pretty much, this is where if you find somebody who does have a lot of medications or has really pricey medications, this is where they're going to fall into. Somebody who only takes, a couple medications and they're lower cost, they're probably not going to fall into this. And then once they do hit that 5,000 threshold, then that's going to, include their deductibles, the co-insurance, and the co-payments. They're all going to go towards that $5,000 and to help kind of bring that cost, hit that cost. When they do hit that $5,000, they'll move into that stage 4, that catastrophic stage. And this is where the plan starts picking back up and starts helping them back out. And it would be 5% for the customer, or $3.35 or $3.35, or for brand names, the $8.35. Once they've spent that $5,000 in stage 3, their costs drop for what their plan, what they're going to have to pay on that plan for the coverage towards the prescriptions. So, it's going to, their cost will be either 5% or whatever that contracted cost is at the $3.35, whichever one is going to be greater for the customer, unfortunately. But they will continue to pay their monthly premiums as well. And the cycle does start back over every single year on January 1st. So if somebody got sick towards the end of the year and it was a really expensive medication, like I was speaking with somebody, they said that they take about an $1,800 pill, and they're, it's they have cancer. It's for that one pill is $1,800. They immediately ate through, that right away, and fortunately it reset for them January 1st. So they kind of had to start back over, or I should say actually unfortunately, because then they had to go back through that deductible again and everything else. So But I did want to throw up some different examples of the different prescription spending and how it kind of looks. So if it's here's a scenario: Helen spends $100 a month for 2 drugs. She enrolls in a Medicare Advantage plan with built-in Part D drug coverage. So it's built in, not standalone. And Helen pays a premium of $32 a month with no deductible. Helen only reaches that initial coverage stage. So Helen's cost with no drug coverage, if she had no drug coverage, would be $1,200. Helen's cost with drug coverage, annual premiums for Medicare Advantage plans, which would be $32 towards times the 1 year, 12 months, would be $384. Her initial coverage stage would be her share would be $250. So coverage gap stage, she didn't even hit it because she's one of those that only has 2 prescription drugs, and and they're not very expensive. So she never hit that catastrophic stage either. So her total pay for that year would be out of pocket $634. Her annual savings with the drug coverage would be $566. So not a vast difference, but she would still have some savings. The example 2 is somebody who actually has quite a bit more prescription needs. So Enrico has several chronic conditions. His drug cost is $950 a month. So Enrico has original Medicare Part A and Part B, and then a standalone Part D drug plan. His plan premium is $32 a month with no deductible. Enrico goes through all the coverage stages. So he has that $950 a month that he pays for his drug costs times 12, which is the year, is $11,400. Now the cost with drug coverage, with being covered, he would have the annual premium for Part D at $32 times the 12 months, which is $384. Initial stage, because he hit that initial coverage stage, that initial coverage limit, $720. The coverage gap, where he fell into the donut hole, where he has that additional cost sharing, he has to hit that limit, $4,230 out of pocket. And then he moves into the catastrophic stage. So his share would be $236. And then his total pay for out of pocket for the year is $5,570. So without drug coverage, if he didn't have the Medicare prescription Part D standalone plan on there, it would cost him, definitely about $5,830 more dollars. So he saved quite a bit by having this, opportunity to have that standalone plan. And then I talked about the low income subsidies, the LIS. There definitely is some opportunity for your clients to receive some additional help in regards to their premiums and go through and get some assistance if they do qualify for it, depending on their income. So in 2017, the beneficiary qualified if they had an income of $18,090 for that yearly income. For a married couple, it was $24,360, and then up to $13,820 in resources, and $27,600 for a married couple. So it does take into consideration some of their resources towards their income, and it helps pay for the prescription drugs as well. So it'll help in related costs of their premium, as well as their yearly deductible, their coinsurance and copays, and it helps eliminate that Part D late enrollment penalty if that incurred for them, and it helps provide coverage in that donut hole gap as well, so that they can receive some assistance on if they need to. And this, kind of breaks down, if they hit that federal poverty level at 100%, their generic and preferred drugs would cost them about $125, or I'm sorry, about $1.25 per, instead of the $335. So they do have that savings there. And then catastrophic limit would be $0. They wouldn't have to really pay anything for that. And then, if they do hit that 100% poverty level and other full, so they qualify for those subsidies for eligible beneficiaries, they don't have any costs on that deductible. It's zero. Generic and preferred drugs would be about $335 for them instead of the what was it, $8, I believe it was. So the $835, and then some of the other costs, depending on what it would be $835, and that is depending on some of the different prescriptions that would be in there. And then you have partial subsidies. So if they do qualify for partial, maybe they're not at 100% poverty level, but they do qualify for some of the income subsidy. Their deductible, it would be lowered to $83. Their coinsurance and initial coverage limit would be 15%, and the generics prescription coverage would be about 15% fee for them that they would have to pay, and then anything above that catastrophic would be $8.35 that they would have to pay towards each prescription. So they can definitely, as I said, if they have somebody who, you come across somebody who has that low income, you see that, and they're not receiving any assistance or any help, you can have them get in contact with their Social Security Administration, then they can get signed up for some assistance on that. And definitely that's something that can tremendously help them out. So you have your Medicare Part C, your Medicare Advantage plans, sometimes called Part C or MA plans, Medicare Advantage plans. They're offered by private insurance companies approved by Medicare. If the client joins a Medicare Advantage plan, they still have Medicare. So no matter what, even if they, they don't have A and B, well, Part C is Medicare Advantage. They'll get their Medicare Part A hospital insurance and their Medicare Part B medical insurance coverage from one of the from the Medicare Advantage plan and not original Medicare. So as I said when we first started, kind of look at C as though you're kind of putting A and B together. So kind of, just formatting how it lays out for Medicare Advantage C. It covers all the services that the original Medicare would covers. So it covers A and B together. And just, kind of your annual enrollment period, very similar to your A and B, nothing different here. You have your proposed effective dates for annual enrollment periods is January 1st. So you go through October 15th through December 7th, and then January 1st kicks in for those. Definitely you have that opportunity to go through, do a little pre-enrollment period, October 1st to the 14th. As I remind you guys, you can double check with your clients to see if maybe they're up to date on their flu shot, if they have any new prescriptions. So you can go through and you can double check to see if they're going to need to keep the plan that they're on, or maybe change their plan because maybe they picked up a whole bunch of new prescriptions that weren't on there before. So you can do some of the prep work beforehand. You just cannot have them sign their applications and submit them until October 15th. Their enrollment period, again, 3 months before their 65th birthday, during their birthday, and then 3 months after. It, definitely is kind of standard format for their initial enrollment period. The initial coverage period, that 7-month period that I just brought up, again, it's 3 months before, the month of, and 3 months after. Then there's the annual election period, kind of reviewing that little calendar, October 15th through December 7th. And this is where they can change plans. This is where they can drop plans. This is where they can, kind of make some adjustments if needed. So they have that opportunity. Maybe they were coming from a group plan and want to come, get signed up for a new plan, something in that regard. And then there's the SEP, the special election periods, and this, again, it's if they move out of that service plan, losing employer coverage, they qualify now for the low income subsidy where maybe they didn't qualify before, or maybe they have a special needs plan that they need to get set up with. Medicare Advantage plans and their special needs plans, to kind of cover this, you guys are pretty familiar, I'm sure, with the HMO plans. If you've been selling any under 65 major medical, your HMO is Generally, they get care from their primary care physician and their specialist, hospital, all within the plan network. Then they have the Medicare PPO plans. They generally will pay less for those if they use the primary care doctors or specialists. And then they have, out-of-network coverage usually will cost them more. So pretty typical for your standard PPO plan. Your Medicare special needs plans, they do provide coverage for specific groups of people, such as those in institutions, duly eligible for Medicare and Medicaid, or someone who has chronic conditions. And then the private fee for service, the PFF plan, PFS, PFFS, there we go. Those usually will actually cost quite a bit more. And they, get to go to any primary care doctor or specialist that'll accept Medicare and the terms and conditions of the health plan. But it usually will cost quite a bit more to the beneficiary for those plans. So to kind of just do a chart of, the original Medicare to Medicare Advantage, you have your original Medicare, what would it cost? Well, that's where we told you, or where I told you before in A and B. Usually they have about a 20% that you look at it as almost like a 80-20 plan. They have that 20% that, they would have to cover. Beneficiaries pay that premium and the deductible and the co-insurance as well. And then the Medicare Advantage plans, your C beneficiary, the beneficiaries do pay that premium of their plan. If it charges one, because not all the plans do charge. And then, they get to, the plan will set the deductible themselves and the co-insurance. So usually it is a fixed cost for each office visit. So, the deductible and copays will vary on the plans that you get them set up with. The supplemental insurance, can they have it? Can they not have it? For the original Medicare, which is, A and B, or A, or B, they can have Medigap plans, but only at certain times depending on where they live. So again, we're going to cover some of the supplemental insurance in this next week. So, there are certain states, depending on where they live, for certain times they can get set up. And for Medicare Advantage plans, they can't have Medigap policies to help pay their out-of-pocket costs in the Medicare Advantage plan. So no Medigap with the Plan C. Covers extra services like vision and dental? No, not for original Medicare, unless it's medically necessary. No, it does not. And Medicare Advantage plans, maybe. It depends on the plan. Some may cover services such as routine visions or hearing, hearing screening or dental screening. So it depends on the plan as well. And then lets the beneficiary just see a provider nationwide wherever they want. Original Medicare, yes, they can, as long as that doctor is accepted by Medicare or that hospital even. And for the Medicare Advantage plans, no, not usually. They have to stay within network locally, depending on the provider and the network that most of them will be HMO plans, so they have to stay within that network. If they have a PPO or the PFFS, then they can go outside of it, but they're going to have to pay more. Do they need that referral to see a specialist? Not with the original Medicare. No, they don't need the referral. And for the Medicare Advantage Plan C, maybe it depends on the plan that they're on. Because it is a HMO, for the most part, for majority of these plans that are sold for Medicare Advantage, a lot of times they'll need to have that referral to see that specialist. Does original Medicare cover drug coverage? No. That's where they have the choice of purchasing a D plan standalone if they would like, but it is not something that is built in. For Medicare Advantage plan, usually it does have a little bit of a Part D drug coverage, either built in or else a standalone plan. They can have that choice. Oops, and I forgot the last one, sorry. And out-of-pocket limits, no, there's no cap for original Medicare. So again, that's something that the customer, if they go to the doctor quite a bit, they might end up having to pay a whole lot of out-of-pocket expense with their co-insurance. So there's no stop loss on the original Medicare. And Medicare Advantage plans, yes, there is a limit to the out-of-pocket. So it can be high, but it can help protect them if their needs are expensive. So if it's, somebody that goes in and out of the hospital quite a bit, this, might help them out. The access to service between the two, traditional Medicare, if that customer enrolls in traditional Medicare, they can go to any doctor in the, or hospital in the U.S. that accepts Medicare. With Medicare Advantage, as I said, chances are they have to stay within network within their location. And then traditional Medicare does not have a network, so there's a huge difference there. You don't need to have a referral to see a specialist, so there is that big difference between the two. And then the cost with traditional Medicare Part A, it's free if you worked or paid Social Security taxes for at least 40 calendar quarters, which is 10 years. If they are on traditional Medicare, they owe a monthly premium for Part B coverage. So A usually doesn't cost them anything. B, usually they have a premium to pay. They may also have to pay for the deductibles and co-insurance on that. Traditional Medicare has no out-of-pocket maximum or cap, as I said. There's no stop loss. And with traditional Medicare, they have to purchase that Part D if they want prescription coverage. Or get set up Medigap plans separately. With the Medicare Advantage plans, they pay the same monthly premium as those enrolled in traditional Medicare B. There is additional out-of-pocket costs in the Medicare Advantage plans depending on what type of plan they choose. And they may include the following: whether the plan charges extra monthly premium or has a yearly deductible, how much they pay for each visit or service, depending on, usually is their co-insurance or their co-payments, and then the type of healthcare services needed and how often they need them, and whether that's a network provider. As I said, if they go outside of the network, it's going to cost them more. With Medicare Advantage plans, it may charge cost sharing for the services above or below the traditional Medicare cost sharing for that service. And all Medicare Advantage plans must have a maximum allowable out-of-pocket MOOP limit on the amount of cost sharing they can charge for all Part A and B services, after which they'll pay nothing for the rest of the year. So once they hit that maximum out-of-pocket expense, then they'll have to, they don't have to pay anything. And Medicare Advantage plans may also charge benefits, premiums, and copays every year too. So the benefits, what are the differences in benefits? Traditional Medicare has a standard benefit package that covers medically necessary healthcare services. Traditional Medicare does not offer coverage for prescription drugs. And traditional Medicare, the customer may have to buy Medigap as well as a separate Part D prescription plan. Where with Medicare Advantage offers the benefit package of at least or equal to the traditional Medicare. So it has that, hospital and outpatient coverage. And then some Medicare Advantage plans may cover services which are not covered under traditional Medicare, such as dental, hearing, and vision care. And a lot of times that's just general screening. And then also it may, help with maybe health club memberships or something. Many Medicare Advantage plans have prescription drug coverage built into the benefit package. So there is that difference between the two. If it's somebody fairly healthy, doesn't go to the doctor a lot, doesn't go into the hospital a lot, traditional Medicare might be great for them, help keep some of the costs down, whatnot. Medicare Advantage, maybe somebody who does have a little bit more health issues going on, needs to make sure they have some stop loss, help them with that, stop some of that out-of-pocket expenses. So kind of varies. Plus it helps with that Medicare prescription coverage built in as well. So deciding between the two, really it just comes down to understanding how the Medicare Advantage plan works and the current coverage that that customer might have if they have a plan. If they have a retiree or an employer health coverage, they will lose coverage if they join a Medicare Advantage plan. So definitely you have to see if they're still working as well. And that's going to, make a difference too. So it kind of helps you decide between if they need A and B or if they are okay to have C or need C. Compare the coverages and the costs available to them. What is it going to cost them if they want to go ahead and go with A, B, and throw D on there as well as Medigap? Or what is it going to cost them if they just go with the standard C plan and then maybe do a standalone D plan? You know, what is going to be the difference? What's going to be the difference with the premiums, the deductible, and the co-payments, as well as the out-of-pocket maximums? And then double check with them about their, services from medical providers. Make sure that it's going to fit their needs. And then the physician and healthcare providers, are they, the healthcare providers that they have, maybe they've had that primary care physician for the last 30 years. They want to make sure that it's, definitely within their network and definitely within their location to have that coverage. So, you just want to go through and do essentially comparison with your customer depending on their needs. And that's honestly what it all comes down to, is the customer's needs and making sure that you're, getting them set up for, something that's going to fit their budget and fit their coverage. Just kind of a review. Original Medicare Part A, coverage for inpatient hospital care, skilled nursing, hospice. It has that high deductible. It does not have a premium usually. So, if they worked, usually I should say, if they've worked that, 10 years or 40 credits, then usually they don't have that premium, but they do have a high deductible they have to meet per benefit period. There is co-insurance and co-pays that they have to pay after the deductible is met. And then there's Part B, their coverage for doctor services, outpatient hospital care. They do have a $183 deductible they have to meet on that, as well as 20% co-insurance. And as I said, there's no stop loss on that. So, and then also you can get a penalty for not enrolling at your initial enrollment period. And with that, there is premiums that they have to pay each month. For Medicare Part C, your Medicare Advantage plan, it replaces Part A and B. And then it has comprehensive medical coverage offered by private insurance company, does include some of that RX coverage, and which is called the MAPDs. And then also may have some additional coverage for like the dental, vision, and hearing screening. And then you have the Part D plan, the PDPs, prescription drug plan. And this helps pay for their prescription drugs, discounted rates after they go through and they pay that initial coverage. Questions. Anytime that you guys have any questions, there's multiple ways of being able to contact me. Please feel free to, you can send emails to training@ahcpsales.com. You can send them directly to myself, which is tammy.stencil, and it can be at ahcpsales.com, or it can be tammy.stencil@vellapoint.com, or tammy.stencil@hst.com. I have multiple emails. Most of the time, if you find one of our companies and you do tammy.stencil at one of those companies, you'll probably get an email to me, chances are. So any questions, please feel free, send them to a chat. I always try and collect all the questions that I possibly can. I want to, go through and kind of do a collaborated Q&A sheet for everybody on some of the questions that have just popped up periodically for people. And so, that's definitely something that I can get collaborated for everybody and see if it applies to any of your questions. Because sometimes people don't want to ask the question, but it just kind of lingers there and somebody will ask it for them. And I can get that, taken care of. No questions? None? Oh, okay, here we go. Definitely, Carlos, I will hit you up and check get some information for you in regards to United Healthcare policies and whatnot. So I'll help you out in that regard. Any other questions? All right. Definitely. I appreciate you guys joining. Definitely, next week we have another training. And as I said, we're going to be be covering that Medicare supplement, Medicare Medigap, going over, when to use it, kind of some comparisons if you use it, being able to just kind of go over some of that detail and information. So please feel free to join us next week. Um, Usually our marketing gentleman Paul sends out the newsletters where it'll have a link that you can register for that. If you don't get that newsletter or don't see that, we always have it up on the AHCP sales website on the training calendar that you can click on it there as well. Or if you just need the link sent to you, hit me up and let me know and I'll get you the link sent out so you can get signed up for that. I definitely appreciate everybody joining today. Thank you so much. And I look forward to seeing you all next week. Thank you.